Okay, everybody. Welcome to our webinar today. I hope you can hear me and see my slides. But my name is Lacey Oviak. I am the Health Equity Coordinator here at the Epilepsy Foundation of Greater Chicago. Welcome to webinar number 4 in our Epilepsy and You series of webinars. If you're able to join our last session, you may remember that we talked about how genetic testing can help identify rare forms of epilepsy. And to further explore that topic, we are going to do a bit more of a deep dive into rare epilepsies and where you can find additional information, additional support. We're also going to learn about telehealth and how it can play a role in care for rare epilepsies as well. As I mentioned, we just wanted to highlight rare epilepsies to kind of expand on that previous conversation about genetic testing. A really big part of health equity is just ensuring that all voices are heard and supported. We know epilepsy is not a linear experience. There are many different forms of epilepsy and different experiences, different needs that might require different kinds of care and support. So, part of our goal in this series is to lift up these kinds of conversations and help more people access information and resources. And this is made possible with our awesome guest speakers today, Ilene Miller and Dr. Millichap. Thank you both so much for being here today.
Thank you.
All right, I'm going to do a little quick introduction of our speakers. Ilene Miller will be speaking first and providing us with kind of an overview of rare epilepsies, as well as where you can seek support, how to find support. She is the director of the Rare Epilepsy Network, or the REN, which is a coalition of hundreds of rare epilepsy organizations advancing outcomes through collaborative research, advocacy, and education. Ilene is an attorney, experienced nonprofit executive, recognized thought leader in the rare epilepsy community, and a devoted caregiver. She also leads the Epilepsies Action Network, which is driving efforts to secure a national plan for epilepsy, which is very exciting. Additionally, she co-leads the Not So Rare Epilepsies Echo series, which brings expert clinical knowledge directly to frontline providers. Ilene has helped shape national priorities in epilepsy research, previously serving as advocacy co-chair for the NIH-NINDS Curing the Epilepsies Conference and as an advisor to the NIH-NINDS Advisory Council. Thank you so much, Ilene. And speaking after Ilene, we will next hear from Dr. John Millichap, who is a pediatric epileptologist and clinical neurophysiologist in private practice at Precision Epilepsy PLLC. Dr. Millichap advocates for his patients and their families, serving on multiple advisory boards for nonprofit foundations for rare genetic epilepsies. Dr. Millichap is actually our chair of our medical advisory council here at EFGC, so we do connect with him a lot and always are glad to have his support. Formerly at Northwestern University, he served as an associate professor of neurology, program director of the Pediatric Epilepsy Fellowship, and director of the Infantile Spasms and Epilepsy Genetics Clinics. Dr. Millichap's current practice utilizes a telehealth approach with a focus on diagnosing and treating rare epilepsies, which is what he's going to be presenting on for us today. Telehealth has really contributed to making advances in connecting more people to care. Barriers that still exist, distance and lack of transportation, are still really major challenges in access. So I am really looking forward to learning more about telehealth and the role that it can play. Really quickly, before we kick things off, as always, I just want to share an opportunity to share your thoughts with us on the webinar. This is a really short survey. It'll take you like less than 2 minutes if you have the time. Please let us know your thoughts. You can scan this QR code, or I will also send a link in my follow-up email following the webinar. I will also send a link to the YouTube page. There'll be a recording of this session if you want to watch it later or if you want to share it with anyone who couldn't be here today. That will be included in that email. And before we get things started, once again, if you have any questions, please share them in the chat. just let us know, and we will have a Q&A session following. We'll do our best to answer all of your questions that you may have. With that being said, I will hand things off to Eileen.
Great. Thank you so much. I'm going to go ahead and share my screen. Make sure you can see it. Great. Lacey, can you see it?
Yes.
Okay,
Perfect.
perfect.
Thank you.
So first of all, thank you so much. I have a real soft spot for the Epilepsy Foundation of Greater Chicago because we've had many years of collaboration around the rares, and I just want to express appreciation as a regional organization for really recognizing this growing and diverse community of stakeholders and families and clinicians, and for all the work that you're doing to raise awareness of the rares. You've been a tremendous partner, and we are very grateful. And it's a pleasure to present alongside Dr. Millichap, too. So, first I wanted to tell you what my why is and just briefly introduce myself. And again, thank you to Lacey for such a thorough introduction. I am the executive director of RAN. I'm an attorney. I've been in the nonprofit space as a leader for a long time. But first and foremost, I'm a parent. 22 years ago, my son was diagnosed with a hypothalamic hamartoma after a 5-year diagnostic odyssey. It's a rare brain lesion. We traveled out of state for what was then experimental brain surgery because that was the best option for my family. That brain surgery is now considered a standard procedure. Like so many other rare families, we were in a race against time to prevent what we believed could be irreversible damage. And there was no roadmap. Every decision felt high stakes, uncertain, potentially life altering. I am so pleased to share that in our personal circumstances, that surgery changed everything. It truly changed my son's trajectory. And today he's a college graduate. He graduated with honors. He has aspirations to go to medical school. I hope he realizes all of those aspirations and become a neurologist. But for most rare families, the reality has not fundamentally changed. We are still treating symptoms, not the underlying causes. So, looking ahead, we're on the cusp of a genetic and precision medicine revolution. Rare epilepsies is no longer on the sidelines. It's really at the forefront. In many ways, it's really leading this revolution. And our families are no longer just hoping for seizure control. They're seeking precision disease modifying interventions. 20 years ago, a novel surgery changed my son and my family's trajectory. Today's families want the same breakthroughs in therapies and in care. And that's really what I'm going to talk more about today. Okay, so how can epilepsy be rare and not rare? And I love to interact with you. So I'd love for folks that are listening, just throw into the chat. Do you think it's rare? Or do you think it's not rare? And you can just throw your answers into the chat. And I'm going to keep talking, but I'm going to be keeping an eye on the chat as well. So it can be both, right? There can be tension between these two things, but it can be both. The disorder of epilepsy is not rare. We all know that. There's 3 million adults, there's nearly 500,000 children. It's 1.2% of the US population. It's the fourth most common neurological disorders. However, many causes of epilepsies, and I use that plural with intention, are rare. What makes a disorder rare? It impacts less than 200 people. So for all of the disorders that include seizures that impact less than 200 people, those belong in sort of this bucket that we're calling the rare epilepsies. Now, I think most people know of the genetic causes of rare epilepsies. And as of last count, there were 1,051 monogenetic single causes of rare epilepsies. But I want to emphasize that much like my son, there are other causes too. My son's cause was considered structural. There are metabolic causes of rare epilepsies. There are immune, there are infectious, and there are even causes that we haven't discovered yet. We just are hyper familiar or really familiar with the genetic causes. I've been in this space for 20 years. I was fascinated to learn more recently. There are 600 metabolic disorders that all include seizures, and 111 of them are treatable with dietary supplementation, medications, and other interventions. So I hope that as we're having this conversation today, we will think about and talk about the genetic causes, but you will leave here with an awareness that there are other causes as well. Um, so there's so many, right? There's so many rare causes of epilepsy, and each one has its own profile. And Lacey acknowledged earlier that no two diagnoses and no two journeys or outcomes are the same. But across the rare epilepsies, there are many things that are the same. And that's what this slide really reflects on. Many do not respond to medications, they're considered refractory. Many have seizures, but they have so many other what are symptoms or comorbidities that can impact every body system imaginable: sleep, learning, walking, speaking, seeing, you name it, respiration, eating, feeding. And these comorbidities are often the rule and not the exception. And even one of the comorbid conditions, if we pull apart gastrointestinal, when I say that somebody might have gastrointestinal comorbidities, that can be broken down into many individual symptoms. So it could be reflux, it could be choking hazards, it could lead to constipation or diarrhea, it could be difficulty feeding, difficulty maintaining appropriate nutrition and swallowing. So I love this slide. I borrowed it from Dr. Ilene Worrell at Mayo. The seizures are sort of the top, they're what we can see, but there are so many others of these comorbidities that can be quite broad and each in their own right, many inclusive. There's also delayed diagnosis. I believe that the diagnoses are getting faster for some, and what used to take years can now take months, even weeks, but not for all. And a lot of times, your diagnosis really depends upon your geography, your socioeconomic status, your education, your race, and your ethnicity. Another important common thing across these rare epilepsies is the spectrum. We have some that are considered DEEs. They are extraordinarily complicated and complex. We have others that at the other end of the spectrum that may be drug responsive. They may have a spontaneous remission. People diagnosed with them may have normal cognition, and we have everything in between. Also common across them is your increased risk of mortality, your need for having a seizure action plan, being familiar with and educated on rescue medications. Another common signature is the frequency of these being diagnosed in childhood, but also an awareness that these can be diagnosed at any age. They are not exclusive to children. And I think with the increased genetic testing as one diagnostic tool and more access to that tool by adults, we may see more adults being diagnosed with the rare epilepsies. The importance of getting multidisciplinary care, getting a referral to a center. And I'm so delighted that part of Dr. Millichap's discussion is going to talk about telehealth. Whether you live in a major city and you have access to a major center, an epilepsy center should not limit your access to experts. There are many experts, and many of whom are available by telehealth, and many of whom are building quite an understanding and appreciation for and experience with these complexity of disorders. And lastly, I'd be remiss not to mention transitions. That's still a struggle across the many rare epilepsies when a person who's been diagnosed in childhood is transitioning to adulthood and making sure that they're getting all of the care that they need. So I want if you leave with no other questions today, and again, I'm going to ask you to put your messages in the chat. How many of you here know that you have a rare epilepsy diagnosis? And if you're comfortable sharing it, throw that in there as well. How many of you know or think that you have a complex epilepsy, but maybe you don't know your diagnosis? And I hope that for those of you that fall into that latter category, you will leave here today and you will ask your doctors, your team, your care providers why, to see if there are still diagnostics that you have not utilized that can help you get to that cause. Now, a couple of red flags for those of you that don't know the underlying cause of your diagnosis that may suggest rare could include things like seizures beginning early in life, seizures that are hard to control, other development that is infected, either delays or regression or autism like features, unusual seizure types. In my son's diagnosis, he had what were called gelastic seizures. These are actually look like laughing spells, but that unusual seizure type was a tip off that we were in a rare domain. An unusual MRI or EEG, having other body systems involved, a family history, seizures that are triggered by illness or sleep loss or fever, um, a workup that maybe is normal, but your symptoms are persistent or continue. And if a clinician says to you, this doesn't fit the usual pattern, these are all things that if you're hearing, if you're seeing, could be a tip off that you could fall into sort of this rare complex, and that you want to, in partnership with your care providers, make sure that you're getting access to the diagnostics that can help you understand what your underlying cause is. It is not enough to know that you have seizures. It is not enough to know that you have epilepsy. Now, I say all that recognizing full well that 50% of all cases are of unknown cause. So we might not get to a cause for everybody, but when I first entered this space, that was 30%. So 20% more people know their cause today than knew it when my son was diagnosed. And I'm optimistic that that number is going to continue to go up based upon the work of Dr. Millichap and others. Why does the cause matter? We all think about, and many doctors are trained to think first and foremost, well, the cause matters if it's going to change how we treat you, right? Is it going to change your medication? Is it going to change whether you are eligible for surgery? Might it change your diet, introduce you to something like the ketogenic diet? And that is a good reason for understanding why the cause matters. But I want to posit with you that there are many, many others. Not only can it change your medical treatment, but it can end the diagnostic odyssey. And for my family, knowing what caused my son's peculiar laughing seizures, that brought to us community, other families that were experiencing the same things, sort of a tribe of people that really became lifelong friends and supporters. It can also help you plan for the future, right? If you have a loved one or you yourself are young in age, things can change at puberty, they can change in menopause, they can change at different sort of life experiences. And by identifying your underlying diagnosis, you can become more aware of how to prepare for, get ahead of, have the right interventions in preparation for those different stages and potential changes. You can learn from others that have gone before you. It can give you access to incredible communities. And I promise I'm going to talk about the Rare Epilepsy Network and all of the supporting communities that are part of it. It can give you access to research and clinical trials. It can help your family members, siblings, loved ones assess their risk and make important family planning decisions. It can make sure that you're ready, that you're aware of SUDEP, that you have a seizure action plan, that you're carrying rescue medicine. It can inform your referrals and maybe introduce you to new care specialists. And psychologically, frankly, as somebody who's been through this process, it can minimize your feelings of guilt, of shame, of blame, and even provide some level of hope and empowerment. I'm not going to spend a long time because there was a whole other webinar on the topic of genetic testing, but I would be remiss not to say that genetic testing is one very important, highly recommended tool to understand your cause. It is not the only tool. There are other tools. There's imaging, there's EEG, there's the importance of a great clinical workup. And so you should be aware of all of the tools, but this is certainly a tool that is growing in popularity. There are many ways to get genetic testing. Do not let anything really be a barrier to your accessing that. And one of the resources that Ren has is a whole digital toolkit on everything genetic testing, and I included a Scan Me link to that here. So now I'm going to spend just a few more slides and really introduce you to the Rare Epilepsy Network and the resources of that network. Ren was founded in 2013, and I was there from the beginning. And it was originally a first of its kind patient reported registry. 10 individual disorders, TSC, Dravet, some of the more common ones, LGS, all came together. And we gathered information from our respective patient communities because individually, we didn't have enough money within our organizations to organize our own registries. By 2019, this small little network had grown to 50 organizations, and now in 2026, we're exceeding 200. Some of the organizations, like the TSC, Dravet, LGS, they've been around for a long time. Others are newly formed support groups who are in the early stages of finding their community of patients. Organizations like SETD1B or Parents of SCAMP 5. And there's everything in between, right? All of these disorders meet the definition of rare, and some are nano rare. Some of these organizations may just have 2 patients in the world. The intersection of the genetic testing, advanced imaging, and other diagnostics, the internet, and now artificial intelligence have collided in a positive way to create more awareness and help connect patients with each other and patients with clinicians as well. This is just a list, and this is information that you can find one stop on the Ren website. And this is a list and resources that we hope that you will look for your community if you haven't found them already. Share this with other people that may be looking for community. Share this with your doctors, with your own practitioners. Share this really with everybody you know. So what do these organizations do? And I want to give a shout out because I think I saw Helen Chen from the LGS Foundation on this call, and there may be others. So if you're here and you're from one of the rare epilepsy organizations, please include that in the chat as well. But this is just a quick view of just a few organizations. And you can see, again, they are organizations that each in their own right provide information, they provide education, they provide research opportunities, they provide support, and they provide community. And I cannot emphasize how hardworking these organizations are. Many of the leaders, the people that founded these organizations, are family members of loved ones themselves. So getting to know these organizations is critically important. Ren is run and led by volunteers, and those volunteers are also caregivers. And I just think it's important for you to know we are a team of 2 paid staff, myself and Vanessa Vogel-Farley, but everybody else that you see on this screen are leaders of rare organizations. So they have a complicated child, most of them. They are running their own foundations. They are volunteering with Ren, and chances are they are volunteering with a lot of other organizations well. They are some of the hardest, most committed, working, compassionate, forward-thinking people that I have ever met or had the pleasure of getting to know. So lastly, just I think 2 more slides. What will you find on the Ren website? We have an amazing newsletter. It's going to go out later today. You can see a little image of it here. We strongly encourage you to sign up for it, to read it. It's everything Ren. It's all the new discoveries, it's articles, it's research conferences, it's really everything. And we welcome your feedback, your stories, your input. On our website, we also maintain a listing of a calendar of conferences upcoming, of awareness days. Our website is full of so much information, so many stories. We have many social media channels. This will be this webinar will be spread across our social media channels as well. Um, we have resources if you're looking for clinics for rare epilepsies. If you're aware of clinics that we're not aware of, please let us know. And as I mentioned earlier, we have an everything you want to know about genetic testing, including how to search for an epilepsy experienced genetic counselor, a downloadable that you can print and take to your doctor to ask them to help you navigate genetic testing. So with that, I'm going to leave you with some homework. I hope if you don't already that you will learn your cause, you will find your community, you will be part of this team of educating doctors and others about the rare epilepsies, and you will share REN resources. And it truly is my pleasure to speak with you today and to learn with you today.
Thank you so much, Eileen. If anyone has any questions for Eileen or any of us, please let us know. Please share it in the chat. Speaking next will be Dr. John Millichap.
Hi, everybody. I'll just share my slides and make sure that works. A pop up, Lacey?
Yes, looks good.
Oh, great. Well, thanks, Eileen. It's a wonderful talk. I don't think I've heard your talk before, and it's a wonderful overview. And I've always uh, looked to the Rare Epilepsy Network for support for families of patients that I was treating. So, thank you for all the work that you've done, and good luck to your son on his future uh, graduate school applications. Um, so, uh, I'm going to talk today about telehealth, and I think a lot of the parents and caregivers and practitioners are all probably aware of it, but maybe not all of the different ways that it can be used and some of the specific definitions and just how it's changed lives since its expanded use in the last several years. So I originally prepared this talk for delivery at a rare epilepsy parent professional meetings, and I think it was well received there, and is still something that I do in my daily practice with a telehealth only clinic with reach across the country. So just a boring definition, but people will be able to get on the same page about what is telehealth. A collection of means or methods for enhancing healthcare, public health, and health education delivery and support using telecommunications technologies.
Bless you.
The types of telehealth, just to put that more into practical sense. So the one we're most familiar with is the live video telemedicine or synchronous, meaning you're on there with your doctor at the same time. So you meet doctor and patient or family meet with live video to discuss diagnosis and treatment. Now, this can be either the provider, so the doctor, to a clinic or a hospital where they maybe don't have a neurologist. For example, yesterday a baby was born in California and was having seizures. So I was able to do a consult to that baby's bedside with the parents and the neonatologist there doing the examination and answer questions about what was happening. They have like a little cart or robot, we call it, with a video camera and a microphone. And I'm at home with my computer like this with the video and able to be a neurologist where there is none. And then for my clinic, I do more of a direct to consumer. So I go to people's living rooms, their personal homes. They use their personal devices to connect with me via video. And that is probably the most common type of telehealth when people think about it. You may not be aware of the asynchronous or store and forward. So there's ways to capture either information in a history, or in my world, EEG is recorded somewhere. It's a computer file, and then it's sent to me days later after it's been processed, and then I put a report in, and then the report goes back to the doctor. So it's actually the same as is a part of telehealth, and that's been done for a long time. But you can also have histories and so on that are packaged up into a summary and sent to doctors, and then their opinions rendered and then sent back. I think traditionally it was always used for second opinions for insurance companies and so on, but with the technology we have now, it can be done through different portals and services. And then remote patient monitoring is something that's used a lot in adult medicine for cardiac patients, for example. Doctors will have different devices that will record heart rate, heart rhythm, blood pressure readings, and send those back daily or on a real-time basis. So it hasn't really hit the epilepsy space yet. We are starting to get there with some of the patients who have implantable um, epilepsy devices that are directly on the surface of the brain, or in areas where the seizures begin, and those can record EEG or impulses from the brain and be downloaded and interpreted by their doctor. So that is a form of remote patient monitoring, which will probably expand in the coming years. And I really got into telehealth. Something good did come out of the COVID-19 era. Sorry to bring that up; it's traumatic for everybody, but it was a disruption for everything, and especially medicine, and for people with children with epilepsy. You couldn't go to the doctor, but you need to go to the doctor because you have to adjust your seizure medications. You have to talk about issues. So telemedicine quickly increased, and it was mostly to people's homes, the direct to consumer, because they couldn't go to another clinic and so on, and still have the benefit of not getting exposed. And I think we quickly learned that things like our conditions like epilepsy and autism were better suited to comprehensive care with telehealth rather than movement disorders or muscle disorders, where the doctor really needs to touch and examine the patient in order to monitor progress and improvements. State licensure was always a big issue, but that was temporarily lifted. Now those requirements are back in place, and insurance coverage was also temporarily not an issue, but now is more complex than that, and but is covering more telehealth than it did before this shift. So here's a child with a genetic epilepsy, 12-year-old, intractable epilepsy with daily tonic seizures. These are brief stiffening seizures, and has an underlying genetic cause. Seizures started at birth, and after a diagnostic odyssey, it was more than 12 years ago now. It took many years to get a diagnosis, doing one gene test at a time, but was eventually diagnosed and tried 20 different treatments, and finally settled to having a more acceptable number of seizures on a fewer number of medications to limit side effects, nonverbal communication, and wheelchair bound. So the usual was face-to-face visits twice a year before COVID, and hospital epilepsy monitoring unit video EEG every year to monitor the subtle seizures. But the family lives an hour and a half from the hospital, so that's 3 hours round trip plus the time at the hospital and the clinic. And I don't know if you guys live in a major city like Chicago, the hospitals downtown, they have parking structures. You have to drive up and follow all the other cars for people trying to get to their appointments at 11 o'clock. And when you finally get a spot, then you have to go to the elevator, and the elevators are always full. So you have to wait a couple of times before you get in the elevator. And then when you get to the lobby of the hospital, you have to wait to check in before you even get up to the clinic. So really, these things can take hours and hours. And if you're coming from the suburbs, racing to get home before your other child's school bus gets home is probably, very stressful. So telemedicine for this family, both the doctor and the family can be more available for more frequent visits. And instead of checking in twice a year with complicated epilepsy, you can check in 4 times a year. You don't have to go through all of the issues I was just discussing about coordinating, spending an entire day. You could fly across the Atlantic by the time you get home from a trip to Chicago from the suburbs. It's reduced costs. Driving in the car for 3 hours, especially today, is a lot of gas, and paying for the parking and taking a day off work. So all those things are alleviated by telehealth, still getting the same input from the doctor. But the limit may be less frequent neurological examinations. But usually at most epilepsy monitoring units, a neurological exam is done upon admission. So that could be done at least annually, and they should go to their primary care physician, who's also doing a physical exam, and if there's something new and concerning, can bring it to the attention of the neurologist. And there's something to be said also with that face-to-face connection with the provider, and maybe more importantly, the interaction with the nurse and other staff, social worker, and so on, who are just there in the clinic along with the doctor or the nurse practitioner, and really do so much more than we probably give credit for, and handing out pamphlets about Rare Epilepsy Network or the Epilepsy Foundation at that time. So some of those things can be lost during a telehealth visit, possibly. And I've been struck by health equity is something we talk a lot about at the Epilepsy Foundation, and health equity in telehealth is the opportunity for everyone to receive healthcare they need and deserve, regardless of social or economic status. So I think having this option of telehealth has helped with this situation. Obviously, it's not alleviating all issues, but some of those communities that may have limited access to care, low income, rural, people of color, immigrants, people with disabilities, people with a language barrier, or people with limited digital literacy. And the barriers to telehealth, not everybody has even a smartphone that could do the video call. Not everybody has access to internet. They may have to access it somewhere like a library. They may not have consistent housing to have the visits done. They may not be able to connect with somebody who does telehealth because in their area or where their insurance is accepted, there are no telehealth or virtual providers. And then language barriers can be difficult, though with AI and online interpreters, a lot of that is improved. Several years ago, the Child Neurology Foundation addressed some of these issues with a grant. I think the grant may have run out by now, but the idea of helping those who would benefit from telehealth accessing it. So they were able to assess the needs of families with child neurology disorders, and if they were unable to access the internet or didn't have a device to have telehealth visits, the grant had provided for them with a hotspot or a device to have these visits. So these organizations like Child Neurology Foundation and the Epilepsy Foundation are able to help fill some of these holes and get them in touch with their doctors via telehealth. And why haven't hospitals been doing this forever, right? And why did COVID have to bring this about? Well, you have to be licensed in the state, or the doctor needs to be licensed in the state that they're standing. So I'm standing in Illinois right now, and I can only do visits with patients that are located in states in which I also carry a license, because we have separate licenses for all of the states, even though it's the same country. And your driver's license works in all the different states. Your medical license only works in one state. So that's quite a hardship, and is a lot of my busy work is renewing these licenses, and I have over 22, 23 licenses now. So covering not all the states, but the ones where I've been needed so far. And a lot of the states are banding together and accepting the credentials from your home state. So other states will say, well, if, like Michigan, for example, will say, if Dr. Millichap's approved to practice medicine in Illinois, then we'll do a fast track to approve them to practice medicine in Michigan, because it's a very thorough process at all the states, so they're willing to accept that previous in-depth evaluation of our credentials. And since the pandemic, more insurance covers telehealth, but it's changing. I can't keep track of it myself, but most of the time, telehealth visits are reimbursed by most insurances, maybe at a different rate or in different circumstances. And why would hospitals not want to do this all the time? Because they've invested a lot in beautiful buildings with clinic spaces, and they're employed nurses and the office staff to meet people at the front desk and check them in. So if it all shifted to telehealth, there would be no need for these structures anymore. And so they were all, during COVID, they were all pretty much empty. There were very limited clinic visits. And we'd have to change the whole workflow as far as the staff in the hospital. And a hospital in a children's hospital in Chicago, covers this space. If we have telehealth abilities, then the doctors from that hospital can then maybe compete with doctors from a hospital that's 3 hours away, or 5 hours away, or across the country, and change the dynamics of where they're getting their income and so on. So it's a lot for administrators who have to keep these hospitals running, and I'm sure they've shifted a lot of things. But there are some things you can only get done at the hospital or in the clinic. But telehealth also has a place. I think I like telehealth the most because of, especially the patients, most of the patients that I take care of, especially after the arrival at the hospital, like or clinic, as I described a few slides ago, driving an hour and a half, being in a wheelchair in a car, then having to go through the parking lot elevator, then the lobby, then the hospital elevator, then the waiting room. And I must admit, I was always running late when I had in-person clinics. I didn't try to, it just happened. And now I'm on time because I can keep things flowing. But I think the family and the children are always more relaxed. The child can be playing in the background in their own living room. The family hasn't had to travel anywhere, and we're able to focus on what really matters, rather than the schedule or run, who's next, or having to get tests done or something like that. That they're might want to get my blood draw and get home. We're running late, etc. And as I described about this baby that's in California being born with seizures, they don't have a neurologist there, and even if they have a neurological concern, or if it on an outpatient basis, with a patient who was recently diagnosed with a relatively rare genetic condition, there may not be many doctors who are, even if you find a pediatric neurologist nearby, they may not be aware of or familiar with the latest treatments for that particular rare disease. So it can be helpful to have access via telehealth. And the child may not even need to be there. You can focus more on the parent and the family issues, without worrying about bundling everything together. You can have more frequent short visits. And these visits may allow families to have multiple doctor's visits in one day. If they keep a kid home from school, they don't have to drive. And importantly, at this time of year, or in the fall as well, less germ exposure and less illness. And Ilene already talked about the common tools for diagnosing epilepsy and the etiology, and that's probably the most important aspect of meeting with a specialist, is understanding why. And all of these things can be ordered and interpreted over telehealth. So I mentioned earlier tele-EEG, so you can have an EEG done at home called an ambulatory video EEG. It's very convenient. It can be, a technician can actually come to your home, or some practices will connect it there, and then you go home, have the EEG, and then come back and have it disconnected. And in some circumstances, it can be very good quality, maybe even better sometimes than some hospital systems. And as I mentioned earlier, I was reading the EEG in California. Not all hospital systems have pediatric neurologists who can, or EEG readers. So I was able to fill that gap there for that hospital. And if you don't read neonatal or newborn EEGs all the time, and you probably shouldn't. It's very complicated for everyone, and it's changing every week or two as far as what's normal and what's not. So it's vastly different, and an adult neurologist who sees one a year is not the best person to be asking to interpret that. And that baby didn't have to be in California. The mother was in the same hospital. The family was at the bedside. At some other hospitals, they would have to be transferred because they had diagnosis of epilepsy, and so they'd be separated from their families, their parents, in the first days of life, which is really tragic. I became involved with this organization, Tele-EEG. They are collecting asynchronous telehealth. Everybody knows what that means now because you described it in the beginning. In Africa and other countries where in areas where they don't have access to EEG or EEG interpretation, and then have volunteer interpreters from US and UK who are sending back reports to help with the diagnosis and treatment of epilepsy. So things like this programs like this are really expanding and making healthcare delivery worldwide and improving the health of and lives of people with epilepsy. And genetic counseling can also be done over telehealth quite easily. You have these persons who are specifically focused on epilepsy, and they can reach underserved populations just as well as the doctors can through telehealth. Another aspect is clinical trials. This is something that's starting to expand. Instead of the participant in the clinical trial having to go to major centers in major cities, with telehealth, it can be safely performed, especially with epilepsy medication trials. You could deliver the medication to the patient's home, have telehealth visits to monitor the response, and have either a traveling nurse or doctor do the examinations, or their primary care physician do any necessary monitoring. So telehealth is available if you're not taking telehealth visits. Some of the time, you should ask your doctor about whether it's available. And it's appropriate, especially for the treatment of epilepsy. And it can increase health equity and inclusion by providing specialty care, specifically pediatric neurologists at home, and hopefully clinical trial availability where there was none previously. Thank you.
Thank you, Dr. Millichap, for that great presentation. I definitely learned a lot about telehealth and how it is able to support more people throughout like rural Illinois and even anywhere, any of the surrounding areas. That's one of the challenges that we experience sometimes in reaching 44 counties that we serve at the Epilepsy Foundation. So I know that telemedicine has played a major role in connecting more people to care and support. Um, if anyone has any questions, we have a couple of minutes left, just a few minutes, but if you have any questions, let us know. Okay. I'm not really seeing any questions in the chat at this time, but I have a quick question for each of you, if that's okay. I'm curious from your perspectives, each of your perspectives, do you have maybe one or two pieces of advice that you would give to get the most out of a visit with your provider when you're seeing an epileptologist? Something that we've been talking about recently is kind of like a guide to how to have a good visit with your doctor, to not be afraid to ask questions, just different things like that. Do you have any advice?
Okay, I'll go first. I think, both as a professional as well as a parent, I just think approaching it as a partnership. And I think having a heightened awareness, we've had exceptional clinicians for my son because he's now, 24 years old. We've had many, both through pediatric and now as an adult. He's doing his own care. But I think that the clinicians, truthfully, that I have the utmost respect for were the ones that frankly said to me, I don't know. Like I was okay with the I don't know, or I will find out, or I have some colleagues I'd like to talk to, or I would like some time to think about it. And so I think, you know, especially for the rares. These are complex conditions. There's so many of them. Not everybody can be 100% up to speed on all of them all the time. There are a lot of resources. And I think that if you approach your doctor as a partner, you're, as a parent, bringing really critical information. You're observing, you're advocating, you're champion, you're connecting different practitioners together. And if your clinician comes to the table as a partner, receiving that information, understanding what their limitations are, being honest and transparent about it, I think you will find that you can have a very meaningful long-term relationship. But it is a two-way street, and sometimes you might find that you're not in a good partnership, like with all other relationships, and you need to look for somebody who will sort of approach it with that, I think, understanding and that willingness to come to the table and be a willing and learning partner.
Thank you. Um, does anyone else have any other questions?
I do have a quick question here from just the education side of it. When we go out into the communities and when families think about epilepsy, oftentimes we hear 1 in 26 and they say, oh, it's definitively not rare. How do we better clarify that there are rare epilepsies, despite the fact that epilepsy itself is not technically rare when we look at the grand scheme of it in some aspects?
I think that's for Ilene again.
I,
Sorry.
yeah, I mean, I defer to Dr. Millichap. I mean, I think you're absolutely right. We have to be able to hold two things at once, right? Like epilepsy, which is a compilation of many disorders. It's not one thing. And I think the best analogy, truthfully, is cancer, right? Like if somebody shares with you they have a cancer diagnosis, probably everybody on this call is thinking, well, what kind of cancer do you have? Is it prostate? Is it breast? Is it, kidney? And then the assumption would be, I'm probably not going to give somebody a breast cancer treatment for a prostate cancer, right? We've adapted to the way in which cancer has evolved, and we need that same level of adaptation for the epilepsies. And so I think if you can use that as a model or as an analogy when you're having that conversation, you'll certainly help us raise that awareness.
Yeah, I echo that. I think it's as I work with trainees in the hospitals, and I see seizure disorder written in the chart, and no mention of evaluation or etiology. I always remind them of that exact thing, that analogy of different types of cancer need different treatments, and different types of epilepsies need different treatments. So that's wonderful.
Thank you. I think that's a great way to look at that. All right. Well, we are at 1:02, so I will let everyone go. Thank you so much to both of you for being here today, and thank you to everyone who joined as an audience member. We appreciate you. I hope everyone has a great rest of their day, and I will send some follow-up resources in an email to everybody as well. So keep an eye out for that.
Thank you, Lacey.
Thank you.
Take care.
Thank you, everyone. This will be on our YouTube channel as well, coming up shortly.
Yes. All right. Thank you, everybody. Have a great day.